For 2 years now, we've been really thrilled to be working with Dr. Georgie Siggers, who's consultant neurodevelopmental paediatrician, who I will introduce you to now. Georgie does lots of different things, and I hope you'll tell us a little bit about everything that you do, Georgie, so people appreciate who you are.
Thank you. Thanks, Jo. It's lovely to see so many of you here tonight. So I'll just start, a little bit about me. I have been a local consultant paediatrician responsible for the ASD and ADHD service in Tunbridge Wells, but I stepped aside from that in April, and I've been kind of quite a strong interest of mine has been refugee children, and Kent has had a particular challenge in meeting the needs of unaccompanied asylum-seeking children. So I do work here for part of the week, and then the other part I'm working to try and develop services to support those young people. And this evening I'm going to just talk about a topic that I feel sort of really strongly about, is that children aren't born naughty. It's a bit controversial, and I'm very happy to be challenged on that. But I'll talk a little bit about, there are some exceptions, but what I really want to talk about is, I suppose, the naughtiness or the unacceptable behaviour that some children present with, and what may be behind that, and really when to suspect a neurodevelopmental cause, because a situation that I come across a lot and would really like to prevent is seeing teenagers where neurodevelopmental cause has been missed. And just recently in Starjumpz we've had a number of referrals of 15, 16-year-olds, and actually when you go back and you look at previous school reports, all of the concerns have been there since very, very early on. And actually those children have really suffered, and their families have really suffered, and they've not achieved as well as they could have done. So it's something that I feel really strongly about, that we have early recognition and early intervention. So then we're just going to talk at the end about when to refer and how to refer. What is naughtiness? So it's basically our sort of, I suppose our idea of what is acceptable behaviour and not acceptable behaviour is something that's derived socially. So I think a good example of that is children going to the cinema. Most children don't have to be taught that if you go to the cinema or you go to a theatre and the lights go out, you have to be quiet. It's just something that is an instinct that you pick up. But actually, if you think about it, it's if they were to start misbehaving or chatting, we would think of that as kind of unacceptable. So a lot of behaviour is our judgment as to what is naughtiness or what is bad behaviour. That was a lovely quote and headline from article from the Telegraph last year from an Ofsted inspection that found that play fighting and disruption was an everyday part of school life, and that many hours of teaching each day were lost to bad behaviour. I suppose I don't need to highlight that to you. But if we then look at behaviour, we have lots of different definitions of it, but I suppose what we mean by challenging or bad behaviour is where children's behaviour is difficult for all of us to manage. And that's really what I want to talk about today. And when we talk about the conditions in a little while, what's really important to remember is that these conditions don't mean bad behaviour, and bad behaviour doesn't mean these conditions. It's the kind of the combination of a neurodevelopmental condition and an environment that's perhaps not working for a child. And that's what you have to really think about, because that's part of the way that you can manage and support young children. And interestingly, we do see patterns of referrals from schools, and it's not just about awareness of the staff about some of the conditions that might be causing challenging behaviour. There's something about the school environments, and many, many years ago we did a study in London. There was a school where we knew children had quite a lot of difficulties that were going there, but we never ever had referrals. And yet all of those children, when they hit secondary school, we would see them, and we couldn't really work out what it was. And it was actually a very, very strict Catholic school, very stark environment. And children with ASD just managed really, really well in that environment. And they had complete predictability, routine and structure. and they didn't have all of the sensory overload that many of our classrooms kind of lend to. So there's a lot about environment that interplays. And I started at the beginning saying I feel strongly that children aren't born naughty, but there are a number of genetic conditions that are associated with challenging behaviour. So children can be born with the risk that they're going to present with difficult to manage learning and behaviour. So we mustn't forget that. And then also, children who are exposed to drugs and alcohol in utero effectively are born with those additional challenges as well. And children who are exposed to neglect and domestic violence, it reshapes their brain, so they can also really struggle to behave in the school environment. So those are the things that we must, not forget and respect. But what I really want to talk about today are the neurodevelopmental conditions that can cause challenging behaviour. So I hope you can see that. And basically they all overlap. And it can be very complicated to work out what is the primary cause, neurodevelopmental cause for a child's challenges. And the other thing that you have to really remember is that it's quite unusual for a child to just have one. So at some point, and ADHD we now know can present at any time up until the age of 12. It used to be if you didn't have symptoms before 7, that wasn't ADHD, but that whole thinking has changed. So young children who may get a diagnosis of autism early on, our kind of medical model is not that clever really, because what happens is they may get a diagnosis, everybody then puts down their challenges and difficulties to their autism. Nobody notices the fact that they've got other conditions as well. And with the way that services are set up, you don't take a child and work out for the child what their strengths and difficulties are. You actually send that child to an autism clinic and say yes or no, and then you send them to an ADHD clinic and say yes or no, or you send them to a DCD or dyspraxia clinic. So many children have what we call comorbidities that are missed. And the other thing is you can wait 2 years to have your autism diagnosis. Someone in the clinic may suspect that there's something else going on as well, and then you wait another 2 years to have your ADHD diagnosis. And that's something that's really challenging for schools and for parents, and something that I'm seeing more and more. The number of children that I diagnose with both ADHD and ASD seems to be increasing. And so these DCD is developmental coordination disorder, which in this country is synonymous with dyspraxia, but in other countries dyspraxia can be used to mean other things. And then sensory processing disorder in the middle. And I would say that a very high percentage of the children that I see with ASD would also meet a sort of description of having a sensory processing disorder, and the same with ADHD. And then also a lot of children with ASD and ADHD will have dyspraxia. So you always have to be on the lookout. If you have one neurodevelopmental condition, is there something else as well? And it's really important, because if you focus intervention and management on one, you'll be, you may not be supporting the child to the full extent that you can. And then dyslexia is often there in the picture as well. And then we mustn't forget learning difficulties, because they can sometimes, particularly moderate learning difficulties, can be missed and confused with everything else going on. So I'm just going to talk about the main conditions there: autism, ADHD and DCD. And one thing just to be clear about is there's been a lot of confusion about what's autism, what's ASD, what's high functioning autism, what's Asperger's. And now the diagnosis is ASD. So it's recognising the spectrum and the umbrella description. And the difficulty is that there's a lot of really good resources out there that have been developed for young people with high functioning autism or for Asperger's, and yet the medics involved are only now allowed to diagnose ASD. So it gets really confusing for families. And then added into that, you've also got PDA. So I don't know if people have heard of that. And that seems to be, it's probably even 5 years ago, most paediatricians didn't believe in it.
What is it?
pathological demand avoidance. So there's a paediatrician in Nottingham who's done a lot of work to get this condition recognised, and the current thinking is that it is a form of ASD, and it's important that parents recognise that. And a lot of the support and intervention is the same, but a lot of the strategies need to be delivered in a different way. So, and it is important that it's recognised, because it does explain a lot. And children who, particularly academically able children who are very rigid and really struggling with defiance, will often fit into this category. So it's something that we're getting more and more families ringing up and saying, well, do you do assessments for PDA? Which I do here. But I think the other thing is that I often see children and families when they're at crisis point. So anxiety levels for the child are very, very high. And for a child with autism, if they're very anxious, they become much more rigid. So they can often present as if they've got PDA, and it's actually they don't. And if you can lower their anxiety levels, they'll be a lot more flexible. But what I do is I explain to parents that their child's clinical picture may fit best to autism or to high-functioning autism or to Asperger's, because that then helps them to access resources, and it's really important, because otherwise they'll come away from here and they'll look on the internet and they won't see much about ASD, and then they'll be thinking, oh, it doesn't make sense, and what about Asperger's? So it's important that we get the terminology right, but as we all know, there's lots of children that do fit those kind of clinical descriptions. And the current sort of figures are probably up to 7 in 100 children are affected. So our recognition and our awareness has improved. I don't know whether the incidence is truly increasing or if we're just better at detecting it. And I think that probably is the case. And just to remind us all, children with autism spectrum disorders have what we call the Triad of impairments, so difficulties with social communication, social interaction, play and behaviour, and then they have a lot of additional associated difficulties, so sensory issues, rigidity, need for rituals and resistance to change, and then they may have unusual body movements, and they may have unusual interests, so interests and fixations with unusual objects.
Excuse me, would you listen to their speech as well? Sometimes is there a possibility?
Yeah, so that's part of the social communication. So
that is still
so unusual tone, intonation, sometimes unusual words that they use. So.
Thank you.
And then ADHD is also a triad of impairments, but a triad of hyperactivity. So children who, and not all children with ADHD are hyperactive, but there is what you may see as fidgetiness and lots of fiddling and tapping of things. It's a bit stereotypical, but boys generally present as boisterous and bouncing off the walls, and girls present as daydreaming, looking out of the window. But you can, there's no rules as such. And sometimes children will be missed if they don't have that hyperactive element. But actually, when we look closely enough, it's there. What they do have to have is the impulsivity. But that, again, can present very differently. So the boys, a typical sort of story will be boys who love to climb, and they will be risk takers. Girls, the impulsivity can present, they can mask it to a certain extent as younger children, but as teenagers, girls with ADHD get into a lot of difficulty with relationships, shopping, spending, risk taking. So that's a key feature there. And to meet a diagnostic criteria, the ADHD has to be causing a functional impairment, so having an impact on school day or on family life. Symptoms can present up until the age of 12. So you generally get a pattern where situation is becoming more obvious. And the key with ADHD, which is different to ASD, is that the difficulties have to be universal. So you see the same level of difficulty at home and at school. And if you have a child where nobody has any concerns at school, but they are bouncing off the walls at home, that isn't ADHD. With autism, we're increasingly aware that there's a group of children who can hold it together during the school day, especially if the school day is supportive and structured. They can look as if nothing's going on at all. But the minute they see mum outside the school gate, they have meltdowns. And that's been really tricky because for a long time, I think the medical profession hadn't recognised that as part of the sort of picture or presentation of autism. And people would be putting that down to, well, there must be something wrong with the parenting. And of course, that has to, we have to exclude that. But there really is a genuine situation where these children have such high levels of anxiety during the school day that when they see mum or dad, they can't hold it in any longer. And when I talk to families about that, and children, I talk about shaking a Coke bottle. And with all the sort of demands of the school day, that bottle's just being gently shaken. And then they get to the comfort and security of home and the lid comes off. And there's nothing you can do about it. So key thing for that is recognition and looking for the really subtle signs. So it will be usually that they're uncomfortable with change. And that's one of the key ways of managing that sort of child, really. So just a little bit about DCD. So children, this is where it gets very complicated because children with ASD can often be very clumsy. And there's something about their sense of where their body is in space that is interrupted. But then children with dyspraxia or DCD will have a history of clumsiness, usually delayed motor skills, and that can be fine motor skills or gross motor skills. And they can also have quite significant difficulties with their social and emotional relationships, as can children with ADHD. But the drivers behind the difficulties are different. So that's sort of my job to try and tease out what that might be. But typically children with ADHD get into trouble with peers because they're just a bit too exuberant and they don't wait for responses from their peers. And they can be a bit, sort of domineering and over the top. Whereas children with autism, it's much more complex than that. But children with ADHD do tend to get to, they can have quite a miserable time because they're falling out with friends. And that particularly happens to girls in teenage years when the friendships become, more complex. And if they're a bit impulsive, they may say the wrong thing. And then we have the whole issue with social media. If you're very impulsive, you'll send that Instagram, whatever it is, and then, regret it half an hour later. So I'm just going to go through when would be good to just consider a neurodevelopmental cause. Because, we also do have to be aware that parenting has a huge impact on behaviour. And it's really, really sensitive because, if your child does have a diagnosis, whether that be ADHD or ASD, the best way you can actually support that child is changing the way that you parent. But that doesn't mean that you weren't parenting well in the first place. But it's a very sensitive area because many families, certainly many families that I see, will have been through that whole journey where somebody along the line has criticised their parenting, often very unjustly, and they would have been sent on a parenting course and they would be very, they'd be very hurt by it. And actually what they're doing isn't wrong, just doesn't suit that child if they have a neurodevelopmental difficulty. If their parenting was sort of suboptimal and they go on a course and they learn new skills and their child doesn't have a neurodevelopmental disorder, then you will see an improvement in their behaviour. But it's really important that we don't sort of blame I know but it's easy to say, well, it might, particularly for the children where they seem to be coping in school. It's very easy to, naturally assume, well, it must be something going on at home. And the thing is, a lot of these kind of symptoms and presentations are also very common in children who are, not being parented as well as they could be. So things to just keep a lookout for is a child who's always on the go, won't sit still, having tantrums, not listening, disorganised, defiant, gets into dangerous situations, gets into fights, can't concentrate, can't wait their turn to speak, and distracted or distressed by meaningless noise. And the other thing I'll just add to that list, I've got another couple of pages of lists, but just at that point is to be really on the lookout for children who are bullies or are bullied. Because it's very, very common for there to be, for children, particularly children who are saying that they're bullied, for there to be a neurodevelopmental disorder lurking there, because it's about the way that they read that social interaction. So, I'm sure you'll have come across those children where there's a pattern, and it doesn't matter what class you put them in, there'll always be somebody who's picking on them, and they genuinely are suffering, but they're reading the situation wrong. And likewise, children who get a reputation for being bullies, obviously there are bullies out there, but children who they can sometimes be misunderstood by the other children, and it's not that they're intending to be mean and nasty, but they've just got it wrong somehow, and they don't. Children with ASD find it very difficult to infer knowledge onto the next situation. So you might have reprimanded them for something, and then they go and do exactly the same but with another child, and they actually haven't realised that that's not acceptable because it's not with that same child. So quite complicated. So children who may not respond, so children where they can sometimes appear to be quite rude because you're talking to them and they're just not giving you eye contact, not responding, or they may be slightly inappropriate in their responses. Children who find judging personal space boundaries difficult. So that's something that you can see also in children where there may be difficult parenting or attachment issues, where they will be over-friendly. Children with ASD can be over-friendly as well, but it just looks slightly different. But I do see a lot of children who get very when you're playing with them in the assessment, they just get very close to you, and it's slightly uncomfortable. So I'm sure you've all experienced that, but that's something to just keep an eye out for. Children who just don't judge when it's the wrong time to say something. Children who laugh inappropriately, so maybe responding to being told off by suddenly laughing, or responding to a child in the class being very distressed by laughing but looking slightly uncomfortable about it. And then, as you said, speaking with an odd intonation or expression. And accents as well. My son has an amazing ability to copy any accent or dialect. And so for a long time I thought, is he going to be on the autism spectrum? But he's just very good at drama. So it's not always the case, but it is a little bit of a warning sign. And children who really can't get very literal understanding, they can't understand metaphors or sarcasm, hence the picture. So literal understanding is a real clue that there's something neurodevelopmental going on. Then difficulty initiating conversation or knowing when to stop. Lacking constant concern for the listener. So that's something I see frequently in ASD and ADHD. So in ASD it's not reading the social cues, but in ADHD it's just that busy brain just taking over and not stopping to listen. Poor coordination. Obsessional ways of doing things. So children who line up there. I've just had a school form today actually where the teacher has described the child needing to constantly line up their pencils and sort them in colour order. So that kind of, and with the younger children, sorting Lego out into colours, trains into size order, that sort of thing. Saw an amazing boy last week who sorted my whole Lego. I've got a massive box of Lego upstairs. I don't know if anyone saw it. And he tipped the whole lot out, and I had piles of all different colours, and I felt really awful when I had to put them all back in the box and mix them all up. But it's a way of getting control back into their lives. It's a real comfort to be able to do that. So you have to, it's something that parents and, we all struggle at what to recommend as to whether to let them do it or to try and interrupt it. And generally they'll be very distressed if you interrupt that. And then talking to you as if you know things you don't. So that's assuming knowledge is a very key sign of autism spectrum disorders. So I had an example, little girl the other day that I was assessing, and she started talking to me about a toy in Toys R Us that she wanted, and she was saying, well, it's the one on the second shelf by the front door as you go in. Just not that lack of recognition that I won't know what on earth she's talking about. And then can seem socially naive. So this is particularly as you get into secondary school. So they're very vulnerable to being misled, very vulnerable to being the ones that are told to go and do something risky, and they just don't read the situation, and then they're usually the ones that get caught as well. So if you pick that sort of sense up. And showing a mismatch between content and tone, so that's in speech. So talking about something, very sad, but with a happy sound to the voice. So I see that quite a lot. Really focusing on detail. So I get children to describe a picture, and there's a couple of standard pictures that they have. But if you give a child, for example, a picture of an angry lion, you would expect them at whatever age to say it's a lion. But if they start to say, oh, there's a really shiny black bit in the middle, and there's stripes, but miss the fact that they haven't told you that it's a lion or a tiger, that's another clue. And difficulty with comprehension, but at the same time being able to recall concrete facts. So you'll often find children, and it's not, I think people used to talk a lot in the past about autistic savants that could do amazing calculations and things like that, but it's quite common to find children who have just an unusual knowledge of history or dinosaurs, football teams. I saw a boy recently who was talking to me about PlayStation, and I was trying to be really cool and show that I knew about PlayStation, and I said some game, and then he completely sort of squashed me because he said, that can't have been PlayStation 2 because that game only came out in 2008 and PlayStation 2 came out in, and I was like, and he was 6. So it's that sort of, if you get that sense, and I would say that, an awful lot of children who are highly intelligent will be somewhere on the autism spectrum. Not all, obviously, but it does seem to be quite a risk factor. And the difficulty for them is that they can have incredible knowledge, but then they'll miss the common sense things. And really what you need to just keep an eye out for is any unusual or inexplicable long-standing behaviour. So I think it's always valid to give children time to settle in when you're first, when you first got them in your class. But if you see patterns that remain or get worse, then I think that's when to be concerned that there might be something underlying. And what might it feel like to be a child with a neurodevelopmental disorder in school? Well, it can be absolutely fine. So depending on the school and the environment. And it's interesting as an occasional visitor to schools. I have some schools that I walk in and I immediately sort of think, oh, this is lovely. I'd really like to be back at school and it's very calm. And I have other schools where I go in and within 5 minutes I've got a headache and I feel really, really stressed. And first of all, I just thought it was sheer coincidence, but there's definitely different sorts of feels to schools. And it must be the same for children particularly with sensory difficulties. And I went to a lovely school just a couple of weeks ago. And from the moment I went in, there was just stuff to look at everywhere. The ceilings had stuff hanging off and bits all over. And, for a neurotypical child, that's wonderful. But for a child with sensory processing disorder, it must be so difficult. And there is a video going around from the National Autistic Society and it's called What It's Like to be a Child with Sensory Difficulties. And if you watch it, it just makes you feel it makes you feel almost sick within a few minutes, because the way that it's filmed, it's very, very clever, but it just gives you an insight into what it must be like for children with really marked sensory difficulties.
So where was that film from?
National Autistic Society. And if I've got a Facebook page, Dr. Georgie Siggers Paediatrics, and all sort of useful films like that I've linked onto there. So some schools, and I think, there are definitely children with ASD who get missed in primary school, and it's not because people didn't see things and do anything about it, but it's something about primary school being more predictable and more contained, and then they go into secondary school, and obviously it depends on the setup of the primary school, because if they've had to from year 3 move classes for different subjects and they're used to having different teachers, then that might actually trigger an earlier referral, because children won't be able to cope with that. But then children with ASD often can't cope with that. With children with ADHD, it's really good because they get natural movement breaks and they get the novelty of a new teacher. But if you're autistic and you've been in a school where you stay in the same classroom pretty much and you have the same form teacher, when you then go to secondary school and you've got 8 or 9 teachers and you're having to move around a big building, that can just be totally overwhelming. And that may be when things start to unravel and then it becomes apparent that there's something. But usually when you then go back in the history, all the features were there, but the child's actually just managed very well. The other situation is an only child. So, you often get parents who will say, well, I always thought that the difficulty sharing was because he was only child and he or she didn't have a sibling to have to share with. But actually only children learn to share. It's a natural sort of instinct. So a lot of children get missed if they're not presenting at school with difficulties, and parents won't have another child to compare to. So again, you see patterns when you have what I call a late referral, which would be a teenager. They'll often be only children, or there will be something about the school environment that has been very containing. So children with any of the neurodevelopmental difficulties are more at risk of having difficulty understanding the consequences of their actions. So in school, this really gets them into trouble. And they really, we think genuinely just don't make that connection. And it must be very frustrating for their teachers when you know that yesterday you told them off for a very similar thing and you'd had a whole conversation supporting them through that, thought they'd learnt from it, message reinforced by home, and then they go and do something which to you looks exactly the same. But it's that thing, they just don't make the connections, so that's the challenge. And then unable to understand the intentions or reactions of others. So it's very common for children on the autism spectrum to not be able to read the subtle changes in facial expression or tone of voice. So if you're having that sort of voice of, I am actually about to get very cross, they may even think that that's quite fun, because they may read that as, oh, mum or my teacher's getting really excited and is pleased with me, and so it will actually escalate that behaviour. But the difficulty is that they very quickly can feel demoralised and a failure. And then things can spiral down, because at the same time as they're maybe not achieving as they could be academically and getting into trouble, then they'll be falling out with their friends. And then invariably home life gets stressful because families want their child to behave in school and to do as well as they should do. So and that's when I'll often see families, is when they've really reached that point, because that's what will trigger them to be thinking about going to see somebody. And when that happens in primary school, there's still a lot of time that you can give to a child, that you can turn things around. And it does, I always say that it's never too late to have if a diagnosis is appropriate, it's never too late. And there's certainly, now adult ADHD assessments and autism assessments are a booming trade, and it's very difficult to find people to do assessments. But someone was telling me the other day about they had a referral for a 76-year-old lady who thought she was autistic. And we all started thinking, and this psychiatrist did do an assessment and diagnosed her. And we said, well, why? And it's a lovely story, really, but her motivation was she thought that in the next few years she was likely to need to go into an old people's home. And she really wanted those people who were going to care for her to understand why she needed things to be in a certain way. So it's never too late. And I think what can also happen very quickly is children's anxiety levels rise. And it's what we think happens is a combination of anxiety and sensory difficulties that really escalate a lot of difficulties, particularly with meltdowns and increased rigidity. So the more anxious a child gets, the more sensitive they are to the sensations around them, the more sensory overload they have, the more anxious they get, and the more anxious they get, the more rigid, because they just cannot cope with anything new. They have to feel contained, and so to feel contained they become more controlling, and that's when it gets really, that's when you might see a real deterioration in behaviour at home and in school. And playtimes can be particularly stressful, and so when I've seen a child where I really sort of can't, I might be getting forms and feedback from school that there really aren't any concerns, and parents are absolutely desperate and they've kind of given me a history that's very compatible. Sometimes I'll go into school, and I've learnt so much from doing that over the years. And actually, if you watch a child carefully in the playground, you'll often see they may appear to be running around with the other children, but actually when you look really carefully, they're not. Or if they get into a situation where something goes wrong in the interaction, they then don't know what to do, so they just withdraw. And I see that also in nurseries. So I've been into a few nurseries where the reports have been that the child can play really well, but actually when I went, they looked like they were from a distance. And obviously in a busy nursery or school class environment, you're not, things can easily be missed. And this child was pushing a car along with another child, and actually to start off with I thought, oh, that's really lovely play, and then when I sort of got closer I realised that he was taking absolutely no notice of him, no eye contact, and actually when I went to interrupt that play he was very repetitive. So sometimes difficulties can be really, really subtle. So just put a few, I think I just put a few red flags for behaviour. We've mentioned quite a lot of this already, but really if you get a sense that this behaviour is becoming quite ingrained, isn't going away, and if behaviour is out of the ordinary and seriously breaks the rules. So, I will quite often get referrals where a young child, 6 or 7, has thrown a chair across a room or has hit the head teacher. And that's the sort of thing that's just, seriously breaks rules, doesn't it? And that's escalating things to a point where there must be something else going on, because most children, even the mischievous ones, wouldn't push the limits to that. And I think if there's any concerns about the child's learning in association with that would also be a red flag. And then if there's any suggestion, I'd have a really low threshold for being concerned about a child who may have been adopted because of the early experiences that they may have had and the risks that neglect or domestic violence, drugs, alcohol might bring them. And then obviously you've got, have to have in the back of your mind, is there any safeguarding elements that I need to think about? So when to refer, and I think you can have suspicions that there might be an underlying neurodevelopmental cause for a child's difficult behaviour, and actually it's right not to do anything about it. But if it starts to have an impact on the child, then that's when I would suggest that parents are, you chat to parents and think about making a referral. And it's really difficult because parents may be at a very different, they might be a step ahead of school, or they may be quite a way behind in that journey. But I will sometimes just have a meeting with parents to talk through some of their concerns. And actually, if there are suspicions that child may have autism, but they're actually doing really well and school haven't raised any concerns, then I would say, well, there's no rush. So I would only, want to put a child through an assessment if it's really going to make a difference to them. So it's about just thinking about what impact that condition might be having on the child. And certainly if you're getting a sense that this child is not happy and not thriving and not doing as well as you think that they should do, that they would be expected to, or you see a deterioration. And then the other case is where, and we do see this quite often, is where families are just desperate, but they don't, like schools will be reassuring them, which is, obviously the right thing to do, but not supporting a referral. So, it doesn't happen very often, but I do think, and I think the sort of most recent situations that I've had that have been difficult have been these children who are holding it together. So you at school have not actually seen anything. But I think if you've got family who are, saying that they're absolutely desperate, they're sure something's going on, then, I think to sort of signpost them to where they might get further advice would be really helpful. Because one of the sort of, I suppose, challenges is that some GPs are very autism aware and other GPs aren't. So some of these families that we're seeing, they may have been back to the GP 3 or 4 times expressing concern, and the GP has just kept saying, oh, no, he's just a typical 5-year-old boy, your expectations are too high. So I think if you're getting that sense, then talk to them about referral. And I know it sounds obvious, but we certainly in the Tunbridge Wells team have had many referrals from schools that the parents don't know about. And obviously that's very difficult when we then ring them up and say, would you like to come to our clinic? So I'm sure that, so it's just to make sure that there's been that, that parents are on board. And I think sometimes what happens is you may have had a conversation with parents and they've said, oh yes, I can see what you mean. And yes, we'd be happy to go and see somebody. And then they sort of backtrack. And then when we do see them, they say, oh no, school haven't said anything. So there's that kind of scenario. And there's, in Kent, if a child is 10 and under, you refer for either autism or ADHD to the community paediatric team in Tunbridge Wells at the homeopathic hospital. And if they're over 11, so 11 and over, they go to CAMS for either ASD or ADHD. And in East Sussex, it's an even more complicated. If you think ASD, then they go to community paediatrics. And if you think ADHD, they go to CAMS.
What's CAMS stand for?
Child and Adolescent Mental Health Services. And CAMS in Kent and East Sussex is all delivered by the same organisation called Sussex Partnership, but they have hubs all over. But all of the services would accept a referral directly from school. So GPs don't have to, which is different to other health, acute paediatrics, for example. And obviously we'd be very happy to talk to families here.
And that's for paying. Starjumpz is paying.
Yes,
Where
yeah,
CAMS is
free.
You wait your turn.
Yes.
And waiting time, 6 months or something like that.
The initial, so the NHS service, they have to see children within 18 weeks of referral. And they're pretty, that's the target, so that's where all the resource is. Unfortunately, what then happens is children get put on waiting lists. So I think, you know, the Kent one is around a year. Maidstone area is worse. And East Sussex, a family came just recently and said they'd been told 2 years. So so that's very tricky.
Once there's a diagnosis, there is a forward referral for help for this.
Well, that's the next challenge, is that the NHS service now, after diagnosis, children are discharged. So
I'm glad I asked.
yeah, and in fact, I mean, the service that we used to provide, and a really good service in London that I worked in, families would come back without the child 2 to 3 weeks after the appointment to just talk through the report, talk through strategies, you know, answer any questions that they may have had that they didn't want to discuss in front of the child. And then they'd actually be seen every 6 months to just make sure everything was going along as it should, supporting schools with strategies, supporting any applications through HCP. Well, it was statutory assessment then. And we also had autism support workers that would link with the family. But it's all to do with funding, and it's very difficult when you've got so many children waiting for a diagnosis to justify the follow-up. And it's terrible, really, because, you know, I say to parents that the best thing you can do for your child is to become an expert in autism, but they can't really do that if the very people that they need to speak to discharge them as soon as they have a diagnosis. So that's tricky. And there's obviously, I mean, there are... we've got a big pack of them, actually, haven't we, of leaflets, booklets about treating autism. There is a charity called Treating Autism, because the thing is, there are lots of people out there that have come up with weird and wonderful treatments for autism. And the problem is, if you've got, you know, most children from the point when they come for a diagnosis to 6 months later, just because of what the parents are doing differently and their greater understanding of their child's needs, you will always see a difference. So if in that time you say, yes, I've had stem cells in Russia, or I've had, you know, this, that or the other, then it will look like it's worked. And so there's a lot of quite dodgy practice out there, but then there's a lot that's really good. So I say to parents, anything that, you know, you think, you know, anything that's safe that you would do for any other of your children or you do for yourself is worth trying. So, and I've certainly seen improvements in dietary manipulation, and that's you know, that's the diets that are recommended are health. You know, the only ones I would sort of support are the healthy ones, not ones where you're only living on fluids, you know, that sort of thing. But if it's just less processed food and cutting out dairy, as long as it's balanced, then, you know, and you definitely see improvements. If a child has very marked sensory integration difficulties, then clearly sensory integration therapy will make a big difference. I think that what makes probably the most difference is reducing children's anxiety levels. Because if you do that, then they become less sensory sensitive, become less rigid. But it's very difficult getting that balance. But we were going to ask for, you know, if there were other talks you would like to have, because you know, we'd be very happy to do a series of talks. So,
How much can you tell us?
so you know, I'd be certainly happy to talk about you know, some of the techniques and things that I recommend to parents. And I do a talk that I've been to a few schools to talk about managing autism, which has gone down quite well. So.
But we do one on the OTs here do one on sensory processing and strategies for helping with sensory needs in school and at home, and so that's something we can do as well.
So, any questions?
Are you seeing sensory processing disorder as a disorder on its own, or are you always going to put it to ASD?
As a medical doctor, sensory processing disorder isn't a diagnosis in our medical classification, so which is quite restricted. We have 2 classification systems that we use, one American and one English, and I use both, but it doesn't exist in its own entity. But I do diagnose it because it's a very real condition, but it's sort of more, I suppose, a clinical description. And I do think I'm sure there are children who have sensory processing disorder on its own, but the majority of them have it as part of other things going on. But I think what I do is if I see a child, in the same way as I would diagnose fine motor difficulties, which isn't, again, a diagnosis, but it's a description, I would sort of list in diagnosis any of those things that I think are impacting, because if you have a child with sensory processing disorder and you're only addressing their ASD, then you're never going to fully support them. So the same way, a child with ADHD who has fine motor difficulties, you may be able to treat the ADHD, but if nobody's trying to help them with their fine motor difficulties, they're not going to improve as well as if you were addressing both areas. So I think it's really important that they are kind of described, but I think also particularly with the SPD, that it's a kind of a diagnosis of exclusion as such, so that you've looked for other things that might be going on.
Dr. Lucy Miller, who came, I think some of you may have come to her talk, she worked with Jean Ayres, who founded sensory integration therapy. She is doing research, and some of her research has found sensory processing disorder as an isolated diagnosis, and she's been fighting very hard to get it recognised.
I'm sure it will in the in the future. I mean, there's all sorts of weird and wonderful things that really kind of you'd think make much more sense for sensory processing disorder to be rather than that. So, yeah.
What's the best way we're a nursery, but what's the best way for us to promote or sell your services to parents that may need your help? Fly a flag and say we know about these wonderful people, or?
Yeah, I suppose just encourage. It's very difficult. I do think it's really difficult for schools to make that first jump, because it's such a sensitive area, isn't it? And it's about some parents are never ready for that, and you get such a range. I mean, I do get some parents arriving here, and I sort of think, my gosh, how am I going to get out here alive if I don't make a diagnosis, because they've pinned, they may have already been on a waiting list for 13 months and they've pinned everything on getting the diagnosis. But I'm really clear with families that actually the diagnosis is only part of it, and it's not really the most important thing. And it used to be that, you couldn't get, and I still get this occasionally, we've been told we won't get any help in school unless we have a diagnosis. Now, I know it does bring some additional things, but it's not, it's not how it used to be, is it? But I think there's a lot that gets sort of muddled up with that. So I think just trying to say to them, actually going to talk, getting some advice about, what could work better to support the child, because undoubtedly early intervention is really important, and the earlier a child is diagnosed, the better their prognosis. So, and I think that's just because you don't get that. You have a child then who is understood by their family and by school, and you don't get that constant sort of battling. And there's such a variation in schools' knowledge of and nurseries' knowledge of ASD. So, then you can, I'm still sometimes quite surprised by certain behaviours. And I had an email, a parent sent me a copy of an email that the head teacher had sent to them about their child's behaviour. And I just read it and thinking, oh my goodness, you could see this happening. So there was an incident, and it was managed in a particular way by the class teacher, and it escalated. And then the head teacher was called in, and this child must have been absolutely terrified by that point and really didn't understand what was going on. So he basically attacked the head teacher because the head teacher was in the way of the door, and kind of that fight and flight. But you could see it, all of the steps that were happening. And it's really difficult when you then read that and just think, oh my goodness, I wonder where they are in their knowledge of how to And it's, you know, whereas other schools, you know, I see that they're already doing this and this, and you know that they can't be doing anything more to support a child, and the child doesn't actually have a diagnosis yet, but they've seen everything and they're managing them as if they have a diagnosis.
So saying as well that Georgie sees parents for a consultation rather than, you know, coming if they're not sure about wanting a diagnostic assessment or if there's a need for one.
Yeah.
Georgie will see.
Yeah, sometimes I think the other thing is that parents do worry about diagnosis being on a child's record. And so I say to them, if I'm going to medicate a child, then I have to share that information with a GP, and I have to be clear that I'm doing that because they've got a diagnosis. But if it's just to give you and the school some advice, then, you know, it's up to them if they share that information with the GP. Because I would much rather that the child is understood and support put in place and no one in health knows, than risk the child where they're not going to let anyone see that child, and then they get to teenagehood and they're in a real difficulty. So it's about sort of balancing risk, and actually a lot of parents then do kind of go away, think about it, and then a couple of weeks later we get a phone call, don't we, and say actually we'd like to book a full assessment now. So it's just where they are in their journey as well. And there's often urgency when the situation has reached crisis point, because you've got such an anxious child and things just aren't working at home or at school. But for other children where just maybe some unusual things have been noticed, if they're otherwise doing well, there's no urgency. But I always say to them then, you know, if you then get to teenagehood and things start to go wrong, you must reconsider this, because, you know, because I think in teenagehood, children, particularly with ASD, they start to realise that they're different to their peers, and that they see their peers being able to socialise well, and they realise, and they just start to feel that there's something really wrong with them. So they can get into very, negative situation, and that's often happening at the time when, those kind of social pressures are increasing, academic pressures are increasing, and actually them just knowing that, there is a name for this, and it just makes you slightly different, and it's not, it's nothing more than that really, and this is how they can understand themselves better.
So linked with that, do you think that those of us who work in the primary or in the prep school setting with the younger ones, where, like you say, some of us might think, what's going on here, but it's the child can manage themselves well enough within the current setting, being the age that they are.
Yeah.
Is there still a place for the school gently flagging up precisely because of this issue, which I personally find I have a personal sort of, or a very strong awareness of what happens once the children leave and they go into the secondary senior school setting, and the whole thing, and then all of a sudden maybe they were always fine at the old school, and now all of a sudden, there's that kind of, it's difficult, isn't it? Because
it's really difficult, and I've had experience of, many experiences of either sort of approach, and one boy that's just, sticks with me very strongly is a boy who was at prep school and was just misunderstood. He actually had a very vivid imagination, but he couldn't judge the difference between fact and fantasy. And so he would play in the playground being a lion, and he would actually scratch the other children, and he just couldn't understand what was wrong with it, because that's what lions do, and I'm a lion. And he was getting, it was clear that the school really didn't understand him. And so we did an assessment, and he was diagnosed. And he is now in the lower sixth. And he has, she would ring me and she would say he's just done his first overnight trip, or he's just done his first school trip. And she was basically his life coach, and every kind of event she was coaching him through. But I don't think anybody would see that boy now and think that he had any difficulties. And he's absolutely charming, doing a very successful, lovely boy. but equally I've seen the other situation, and I've seen children go into secondary school and it all goes wrong. So
from experience, current experience, I work in a secondary school, and we've had transition from year 6 year on year, and I suppose the last 2 years we've had young people coming in, and I've had no information from the primary school about young people who have got specific needs. It's certainly, from what you said right at the very beginning, to do with the environment. A very small rural school then going into a 1,300 place secondary school is just too much. And of course, that knowledge of having an awareness before he came, being able to do a really in-depth transition would have helped him so much. And we do that, but because they felt that he coped in his little environment, he wasn't flagged until the day he started transition. He's now got an educational healthcare plan, and he's still with us, and he's gaining confidence about the environment as well as working in the secondary school. So he's doing really well. But it's not just one, it's quite a few.
It's really
so anybody working in primary school, and any condition or anything, I would support that. Just if it's a conversation with the teachers in secondary school to inform them.
And I think for some parents the words ASD or ADHD or autism are very emotive. So I think actually, you know, it's how you approach it and how you explain it. And I think, you know, it's probably a good idea to just talk about thinking, you know, there might be something medical underlying this, or something developmental is maybe a way, or just say, you know, just going, making sure that everything is okay, because these are the things that we've noticed that are different to the other children.
Georgie also offers a developmental check, so it's just coming for a check to make sure everything's okay.
Do you ever go into drugs or treatment like that?
Sorry?
Drugs?
I treat ADHD, but alongside behavioural techniques, but, you know, not with careful consideration. I'm quite a cautious prescriber, but it definitely has its place, and it can make a huge difference to children. So I do feel, you know, and most of the parents I see come very sort of anti-medication, because there's so much bad press about it. But, you know, the difficulty is, I think in the past it's been used to treat conditions that weren't ADHD. But if you give ADHD medication to ADHD children, it works, and it really does improve their lives. So, and, you know, you see them blossom. So
They come off it after that.
yes, and they can just take it school days only. They can have weekends off, school holidays off. It's a very flexible approach now. So they just have it when they really need it. And, you know, some do better having it all the time if they're really challenging at home as well. But then I also treat anxiety in ASD. Not often, but there are certainly children who are just absolutely crippled by their anxiety levels. So, and if it gets entrenched, it actually doesn't matter what parents do or school do to try and alleviate it. You know, the child is kind of stuck in these very high anxiety levels. So some children respond quite well to a low dose of anti-anxiety treatment. And then sleep is the other area. So it's very common for children with either ADHD or ASD to have sleep problems, and so that kind of contributes. So if they're awake all night, then, you know, they're not going to be able to cope as well the next day. So there's a lot of work that, you know, needs to be done before you start treating for sleep, but, you know, there is definitely a place for that as well.
So do you look after, so you can see children who've got problems with sleep?
Yes. Yeah.
With the voice thing you said, I know a couple of boys who've got very peculiar voices. Would that be a speech and language therapist area to go down, or would that be?
If there's no other concerns, then they ought to be seen by a speech and language therapist and somebody in ENT, because it could be a physical vocal cord difficulty. But if it's associated with other unusual features, and the difficulty, you know, I have got children who've got unusual cysts on their vocal cords, but also have autism. So you can get both as well. So
Okay, thank you, Georgie.
no, it's a pleasure.
Really